Good evening, everybody, and Happy New Year. Welcome to the first Fireside Chat of 2024. My name is Dr. Mazhar Amirali. For those who don't know me, I'm a specialist physician and a nephrologist, but also working with AHN in the capacity of Deputy Chief Medical Officer and Country Medical Director for Tanzania. Today we have Professor Nysather with us, who is an assistant professor of medicine at the University of Cincinnati. He's an adult nephrology consultant for tuberous sclerosis at the Cincinnati Children's Hospital, and he has completed his nephrology fellowship from the University of Cincinnati. He'll be taking us through tuberous sclerosis, which is a genetic condition that is fairly rare, and unless if you've seen it or at least seen a patient, it's usually very difficult to recognize this illness. And he's going to get us through the case-based understanding of adult and pediatric perspectives of tuberous sclerosis and the kidney. You're very much welcome, Prof. Please go ahead.
Thank you. Thank you. Thank you for the warm introduction. Again, my name's Jacob Nysather. I actually have a little bit of ties to tuberous sclerosis. My wife and youngest daughter both are blessed with the condition. So that is how I got involved with nephrology in general, and as well as this specific clinic. So a little bit about today is we'll just kind of go overview a different couple case scenarios, give an overview on what it is, the renal or kidney involvement, and the generalized aspects of the treatment. So up front, I have no financial disclosures. And then objectives for today, ideally we want to identify common clinical and genetic characteristics of tuberous sclerosis. The kidney manifestations associated with TSC, and generally what do they mean for the patients? And then what treatment options are available for the aforementioned kidney disease? So case number one, I have a 14-year-old girl who was evaluated in the ED after a motor vehicle accident. CT imaging revealed a total of 5 simple cysts, 2 on the left and 3 on the right, with a solid mass noted on each kidney. The right was 7 millimeters at -7 Hausfeld units, and the left was 4 millimeters at -5. Lab work was unremarkable, and after a brief observation was discharged home with follow-up recommended with nephrology for incidental kidney lesions and cysts. Upon further history in your clinic, you find 3 hypopigmented macules, skin-colored telangiectatic papules of a variety size over the face that she calls acne. Was more prominent over the last few years. She reports a history of seizures, last at age 5, was told she would ultimately grow out of them, and has no family history of any neurologic or kidney disease. And here is an example of a picture of what she describes as acne. So you suspect that she has tuberous sclerosis complex, but what are you're unsure if she meets the criteria for this diagnosis. Okay, so what is TSC? It's a monogenic multi-system disorder characterized by benign tumor formation in multi-organ systems. The key is benign. The primary things that we do see is more in the neurologic system, in particular the brain. We do see a lot of skin lesions. Early on in the heart, lungs tend to be a little bit later in life, as well as the kidneys actually have a very wide array from early presentation to more primarily adolescent time frame when we start seeing a lot of these. Now, despite there being a common genetic etiology, the composition and timing of all these lesions vary very drastically across all these different kinds of tissues. The inheritance pattern is described as autosomal dominant, but really that's only about 1/3 of the cases. Majority of them are actually sporadic mutations. We'll explain shortly on maybe why that's the case, at least why there's not a heavier distribution on the autosomal dominant pattern. And again, because of this, there's a 50-50% chance that a mother will pass it down to her child. Now, the overall incidence is ranged anywhere from 1 to 6,000 or 10,000 births. So the prevalence really is about 1 million worldwide, and it's across all racial groups and ethnicities. Uh, there is no specific time frame in relation to death. What is our age of life expectancy? It is not something that we label as 20 years old, 30 years old. But actually, a lot of patients can have an overall sense of a normal life per se. Now, what we hear about in textbooks is described as VOTS triad, which is the facial angiofibromas, a developmental delay, and then intractable epilepsy. But realistically, in practice, this only occurs in about 40% or much less of these patients. Now, here's a good demographic on time frame on how some of these symptoms across these systems can present and progress. So typically early on, you're going to be seeing more rhabdomyomas or cardiac involvement, often neurologic involvement very early on in life and skin as well. Or kidney involvement tends to be, again, more adolescent age, where we see it a little bit more prominently, 5 to 10 years old, and so on and so forth. And then generally after puberty, in the early adulthood with the pulmonary condition. So here is the updated international diagnostic criteria guidelines. They help with, when to expect the disease, what do we need to do to help diagnose it, and surveillance for this, as well as some of the treatment. So here is table 2, or the diagnostic criteria. Ultimately, you need either 2 major to classify as tuberous sclerosis, or 1 major and 2 minor. And in the case example, for case 1, this patient does meet that criteria with the hypomelanotic macules, the angiofibromas, and the angiomyolipomas as described. Now, here are some pictures of different manifestations that we see more dermatologically that are labeled here. So some of these may present and maybe what you see that are a little bit atypical. So again, as you can see, the angiofibromas may be very drastic in some patients, but then again, may be very minimal in other patients. Now, I do have a hyperlink here. There is an association called Tuberous Sclerosis Alliance that is a very good resource for both patients as well as healthcare professionals that do also set up funding and kind of congruent research for what's going on actively across the globe. So genetics, as I mentioned, it is an autosomal dominant. It is a loss of function mutation in either TSC1, which is Haymartin, or TSC2, which is tuberin. Okay. There have been over 18,000 different mutations identified that have caused these loss of function. Okay. But in clinical practice, 90% of these mutations that we see are noted in the clinical symptoms, but there are 10% that are negative on genetic testing, but may have clinical features of it. So some may have what appears to be a genetic condition with or a genetic association with angiomyolipomas, or LAM for the pulmonary involvement, but they don't have one of these mutations that are noted within either of these genes. And we typically coin these mosaic presentations. Now, some of these, if we were to biopsy the AMLs, for instance, may have some expression of abnormal TSC1 or TSC2 genes. Now, TSC2 tends to be 3 times more common than TSC1. It is a lot more predominant in the renal or kidney world and disease processes that are going on. Now, when we look at the chromosome 16, the TSC2 gene is right adjacent to the polycystic kidney disease 1 gene. And there is an overlap, which we call a continuous gene syndrome, that can occur in about 2 to 3% of these patients, which have very early onset polycystic kidney disease, again, at birth, early childhood, that is fairly rapidly progressive at that time, that is maybe a little bit more so than what we would typically see even in the AD-PKD population. Now, what do these do? So tuberin and hamartin are two proteins that bind with TBC1D and form this complex. And this complex ultimately dephosphorylates what we call Rheb, which would inhibit the mTORC1 from being activated. Now, when these don't work, the mTORC1 is just always active, and it can stimulate biosynthesis, angiogenesis, and ultimately cell growth. So here's one visual here. Again, we can see the TSC1 and TSC2 gene here, where the complex does not work and causing the dephosphorylation, and ultimately you have a continually active RHEB gene and continually activating the mTORC1, which then leads to more biosynthesis and cell growth. Here's essentially the same picture, just in a different format. Adds a little bit more color to it, a different way of looking at it, but again, tells the same information that we are seeing. Now, there's a lot of debate on the presentation, or why is there a large differential or variation in the clinical presentations. If I have a mutation in this gene, why in some do the renal diseases show up a little bit more earlier, or some not at all, or far and few between? Okay, so essentially we have the initial germline inactivation, whether it's TSC1 or TSC2, and then that can, be sufficient to prevent some of the syndrome features from occurring. But then we have some additional second hit that goes on that can cause the loss of this heterozygosity and can cause further activation of this in occurring. And a more recently proposed mechanism here showing that in timing of that second hit may present and lead to more predominant cystic disease versus AML presentation in this. Now, in particular with AML, it is a very high association with lymphatic angiomyolymatosis, which is also abbreviated LAM, which is a pulmonary disease. And the thought process is still a little bit misunderstood on where does this originate from. Now, one thought is, hey, we live in the lymphatic system and we metastasize to other tissues such as the kidneys or the lungs at that time. There have been some reports in double lung transplant patients that have a reoccurrence of LAM occur. And then the other is, again, within this second hit mutation or hypothesis on where it presents within the kidney or the lung, or at what time frame during development can this ultimately fade to one side or the other or both. Okay, so it's still not fully understood in the development process, but these are the most current hypotheses that are going on with why there's such a variable presentation. So case number 2. I have a 26-year-old female recently diagnosed with sporadic LAM after a spontaneous pneumothorax 1 month postpartum of birth, after her second child that required talcopleuridesis. As part of her evaluation, she was diagnosed with TSC2 with bilateral AMLs, the largest, which was 32 millimeters on the right, and a few simple cysts noted as well that were either 6 millimeters or less. So she has a couple questions for us. Number 1, is this cancer? Since they are tumors. And number 2, am I going to need dialysis? So jumping into the kidney manifestations, overall, the kidney contributes to one of the top 3, if not towards the top in older individuals, is cause of mortality. Now, early on, the neurologic component and even the cardiac component tend to be a little bit more prominent, but as we progress with age, the kidney aspect tends to be more involved. Now, as I mentioned a little bit with the contiguous gene where you have TSC2 and PKD1, we see an association with more renal manifestations on the TSC2 side than we do with TSC1. Now, the first type of lesions that we have are angiomyolipomas. Now, there are sporadic AMLs which can occur, and it is very common worldwide. More than 10 million people have AMLs. Now, approximately 1/10 of those are associated with a genetic condition, in particular tuberous sclerosis or LAM, and it affects about 80% of individuals with TSC and 60% with sporadic LAM. So you can see with almost certainty that if you do have TSC, you will have some kind of renal involvement, in particular AML, up to 80% of the time. Now, what makes it more prominent that I need to think of a genetic association versus this sporadic association that tends to be more common? Well, you see more that are multiple AMLs, bilateral, and younger onset. So the average age of onset is about 10 years old, where you're starting to see this. We're on more of the random occurrence will tend to be seen 30 to 40 years old, and often a lot smaller at that time. So size is a big differential as well. If I have a 20-year-old female that has two AMLs and one of them is about 7 centimeters, that tells me we're favoring more of a genetic condition compared to somebody where we see maybe a 3 millimeter uh, in her 20s. So these are not usually detectable around early childhood, at least from an AML perspective, but tend to end up having more of a rapid growth during adolescent and early adolescent periods, again with the growth process and the increasing incidence with age. So the older these patients become, the more AMLs they can develop or can be seen or having higher incidence, again with age. And it tends to be more female favored. There has been some research more specifically with the LAM component that they are estrogen sensitive. So those with a high uh, environment of estrogen, and we do see this with pregnancy in those with AML, tend to have a faster occurrence or faster growth or complications related to these. Now, there was a nice retrospective review from Tosca, which primarily was done over 31 different countries. Now, I know this table can be a little bit more daunting just with all of the information, but the main things I really want to point out here are the differences between TSC1 and TSC2. Those with TSC1 mutations tend to be older when we see the renal manifestations, and those with TSC2, as mentioned, closer to 9, 10 years old. Often end up having multiple bilateral and larger, as we can see with this second part. And then the third part is hematuria or hemorrhage. So complications that we can see that I'll be talking about in a few moments as well, which tend to be seen a little bit more prominently in TSC2. Not that it can happen in TSC1, but again, a lot of the data that we are able to capture tend to favor TSC2. So what is an AML? It's a perivascular epithelioid cell tumor, or PCOMAs, is part of the family, and it has both smooth muscle and melanocyte differentiation. So when we see them on imaging, we tend to see more solid masses. Okay. Histologically, they can contain blood vessels, they can have smooth muscle or adipose-like tissue, and we would call these more of a triphasic or classic or typical component. We tend to have all three of these within the lesion itself. They do not have a malignant lesion or a malignant association with it, and these are the predominant lesions that we see. Okay. In association to the sporadic AML that I mentioned is more common. These again are very, very, very common, where we are looking at 90+% being this type, where in tuberous sclerosis or sporadic LAM, we see this about 70 to 80% of the time as a predominant lesion. Now, although all three lineages are there, we tend to see about 1 to 2 lineages be more predominant, whether it be vascular, adipose, or muscle. Now, the opposite, we have atypical or fat poor or fat invisible lesions. And these have a very high mitotic activity, and they tend not to have very many blood vessels or fat cells associated. They tend to be a little bit more aggressive in their growth pattern, and it has been noted with nephrectomies or partial nephrectomies in the past to have local recurrence after resection. Now, these may be a little bit difficult to differentiate from renal cell carcinoma, which we will, again, we'll talk about here in a little bit. So here are some general pictures on AML. So on the left, we have a few larger AMLs overall, pointed out with the arrows, and then a coronal view as well. In the center, we have just gross pictures of what we're looking at when a partial or a nephrectomy occurs, or even post-mortem, on what our kidneys are looking like. Now, on the right, we see this is actually all three images are from the same patient. Now, there are cysts predominantly noted, but as we can see on the left kidney, right here is our AML with this little bit of a highlighted region, shows maybe there was a hemorrhagic component or a little bit of a bleed at some point in time within this AML. But all these other lesions that we see are cystic components. But just wanted, I thought this was a good image on looking at different weighted images from an MRI and different viewpoints in showing the difference between. Now, complications. Well, the biggest thing that everybody worries about is we are at an increased risk of bleeding. We see this more predominantly in the hypervascular types. When we look retrospectively at it, they tend to be more with the AML being greater than 4 centimeters. So almost all with a life-threatening bleed tended to be 4 centimeters or larger on these imaging. But that may not be the best diagnostic criteria to jump ahead and try and remove these AMLs that we'll talk about in the management section. But aneurysms, we tend to be a little bit more sensitive and specific when we can narrow down the aneurysms being greater than 5 millimeters. It is a higher propensity of having a bleed because of that. Now, again, looking back at the risks of everything, again, the variation in size, just because we hit 4 centimeters does not mean that this patient's going to have a bleeding AML. The actual average size on a few different retrospective studies throughout the world have shown very variable presentation, anywhere from about 4 to 6 centimeters up to about 23 centimeters, for an average about closer to 8 to 10 centimeters when all averaged together. But again, when we're able to capture aneurysms or microaneurysms, it tends to be a little bit better as a predictor of a bleeding complication because of this. Now, it can invade adjacent renal parenchyma, which can, again, distort that normal tissue that we have and can lead to chronic kidney disease. And again, just damaging some of that good tissue that we have. Now, again, looking at the TOSCA data set here more recently, we can see that the hemorrhages tend to occur a little bit more in the older population when they do occur, okay? Again, it can happen when we see AMLs being a little bit more present between 9 and 14 years old, but the risk tends to occur the older that we get as well. Now, again, this is just a highlight of what we're going through, walking down different types of kidney manifestations related to TSC. And next, we're going to be talking a little bit about cystic diseases. So prevalence is up to about 50% of patients. We tend to see this a little bit more predominantly in the earlier pediatric period. Again, more associated with this TSC2 mutation. So as I mentioned, where AML is a little bit more prominent in the adolescent time frame, and our average is about 9-10 years old, we start seeing these cysts, or can start seeing these cysts as early as in utero or right after delivery as well. Now, the continuous gene that we've kind of already talked about, it is a severe progressive disease that can lead to renal failure very early on in life. So it is something that we very frequently pay attention for in screening those patients that are high risk, or those with mothers with a diagnosis of TSC within the workup during pregnancy. Now here's some nice pictures. Again, the the left side where A and D are the images more predominantly that I want to point out. Where image A was actually an intrauterine image at 36 weeks, and D was, I believe, 24 weeks post-delivery. So you can see very early on, we have a very large predominant cystic disease for those with this contiguous gene syndrome. And then on the right, just showing different variations in pediatric population on, again, the cystic presentation that we can see. I believe a majority of them were between 5 and 9 years old that are seen here on the images on the right. Now, as mentioned with the case, one of the biggest concerns in hearing the word tumor is what's the association with malignancy? And RCC has thought to be a very prominent uh, condition because of the unregulated growth. But ultimately, it tends to be about the same as the general population, as anywhere from some studies say 1%, some say up to 4%. But looking at a majority of the literature, you're going to be finding anywhere from 2 to 4%, which is very similar to the general population. Now, a big difference is here is you're going to have an earlier onset. So those that tend to have carcinoma associated tends to be younger in age. Again, more of that fourth decade of life compared to maybe more of that sixth, seventh decade, as we can generally see with RCC. Now, again, whether this is just more of a bias that we tend to see in those patients that we are able to diagnose, we actually do see a little bit more of a predominance on the TSC1 side with this. Again, is it more of a sample bias and a small sample size? It very well could be, but that is a trend that we can see. Now, as mentioned, with these atypical lesions or fat poor or invisible lesions, sometimes these are a little bit tougher to see or help differentiate between the two, and often get mistaken for cancer. So it is not uncommon that I have patients that get referred that have already had 3 different nephrectomies by the age of 30 because they had these AMLs that were diagnosed and mistaken for cancer. Now, in these atypical ones, it is reasonable to follow up with frequent imaging just to develop the rate of growth. With the RCCs, they tend to be a little bit more aggressive in this population. So when the rate of growth is very small or very small within a year time frame, we tend to favor a little bit more of it being an AML. Now our radiology colleagues are able to do some wonderful things, and now with MRI imaging, we are able to tell a little bit better on some of the features that do point to tend to be more RCC related. But in those that we still are unsure, a biopsy is the next step. We want to take a look at this, and in particular, we want to use an HMB45 stain, which is positive in AMLs, but would not be positive in RCC. So that is one of the distinguishing characteristics that we look. So if there's any concern, rather than taking out the kidney as a whole, we would want to biopsy that tissue and take a look because there are complications associated with, again, nephrectomies. Now, chronic kidney disease. Now, we kind of summarized the 3 different types of kidney manifestations. All of these can lead to chronic kidney disease and things that we've noticed with tuberous sclerosis in general. Now, approximately 40% will have at least stage 3 CKD by their 5th decade of life. So 40 years old or older. Depending on where you look, again, there's still a very prominent subset that have chronic kidney disease at least stage 3 before that 40 years old. Now, there is a functional decline. This could be due to multiple factors, whether these AMLs have a mass effect or some invasion of that local tissue because of that, distorting the normal parenchyma, or did they have a complication or a consequence such as a contained hemorrhage, Or did they have an intervention that was done, such as an embolization or partial nephrectomy or whole nephrectomy? And then the complications associated with that of hypertension, which then further add to the negative effects of chronic kidney disease if left untreated. So it's likely a combination of all the above. Now, what is the association between those that are requiring dialysis for tuberous sclerosis? Well, in the literature, it's relatively low, listed anywhere from 1 to 3%, but there is some literature that says maybe up closer to 7, 8%. But I think there are a lot of different factors that could play a role that we'll talk about in the management population or the management aspects of this. Okay, so in summary, again, we have a few different lesions here. Again, more commonly AMLs with cystic diseases and RCC following up. Again, chronic kidney disease is seen in at least 40% of the population by the fifth decade. And likely there is going to be a combination of all of the above in these patients. It's not just going to be AML. It's not just going to be cystic disease, but likely a combination of more predominantly AML, CIS, and CKD. Now, following up on that case, well, the patient goes, well, thank you for answering those questions, but what do I need to do to follow up to stay on top of this? So ultimately, we want to do serial imaging where MRI is our imaging modality of choice. Again, it has a higher yield for looking at these fat poor or fat invisible AMLs, or even those microscopic lesions there. Now, some may have vagal nerve stimulators or other implants that prevent us from doing an MRI, and a CT would then be favored to have that similar characteristics that we've seen for an MRI. But ultrasound would be an alternative modality as well. Again, we tend to favor this a little bit more in the pediatric population and can be done for serial monitoring if we're able to time it up with an MRI and CT and an ultrasound to show what we're able to see with the both modalities at the same time with serial monitoring with ultrasound from time to time, or if there's a change looking at an ultrasound that can space out some of these MRIs and CTs in particular. Now, we recommend about 1 to 3 years for the entire life. So at diagnosis, we do imaging at diagnosis. For some, that's at birth. For some, again, more adolescence or early adulthood. But again, we're looking at these in serial imagings about 1 to 3 years. Those that tend to be more stable, slow growing, we definitely expand that out closer to the 3 year mark, or in some cases longer. In others, we see a little bit more of a rapid growth, or hey, we started treating this AML, or was refused or did not want to treat with certain medications. So we want to stay on top of watching the rapidity of this growth, and if we need another intervention at that time. Now, other things that seem fairly straightforward, but we want to follow at least yearly with renal function, proteinuria, and blood pressure assessment. Again, we do those more commonly in those with chronic kidney disease, but it is something that's very important, again, in that younger population that might not be as willing or on top of their health as what we would expect. So now I have case number 3. I have a 32-year-old male with significant developmental delay who was diagnosed with TSC1 at the age of 3 due to epilepsy. He's accompanied by his parents, who are the primary decision makers for him. They have been reluctant to see a nephrologist, but due to increasing size of his AMLs, the largest, which is now 53 millimeters, they are agreeable to see him. So they ask you, what are the options for treatment for these kidney tumors? Now, when we talk about treatment options, we want to look at the goal of treatment. Our goal is to preserve as much normal renal architecture as we can, while also decreasing the risk of spontaneous hemorrhage. So again, the predominant lesion is going to be an AML, and what are our options here? So mTOR inhibitors have been around for quite a while. They're a little bit more maybe familiar on the transplant aspect within the kidney world. But over the last 10, 20, maybe 10, 15 years, we've been looking a little bit more particular with mTOR inhibitors and TSC, again, trying to get a targeted therapy to help. So about the year 2010, we did a phase 1, phase 2 trial here, looking at sirolimus at TSC and or sporadic LAM with AMLs. So it was a 24-month non-randomized open label phase 1, phase 2, where patients got sirolimus for a year and then had discontinuation of the medication at that, and then had follow-up for further out. Now, dose adjustments were started very low, and on serial follow-up of every 2 to 3 months, if a reduction was not seen of about 10% based on troughs, they were increased or up titrated on that sirolimus dosing. Again, the 3 different trough variation markers were anywhere from 1 to 5, 5 to 10, and 10 to 15. And by the end, in about 24, 25 patients, we were able to see about a 50% reduction in AMLs during this. Now, we also did see in that follow-up period of the, I think, 12 to 14 were willing to follow up a little bit more consistently post that 1 year. Once we stopped the medication, we had an increase back in these AMLs, maybe not to 100% of what they were before treatment, maybe more about 85, 90% within a year, but we can see that rebound effect after stopping treatment. Now, this led into a second study looking at everolimus, which is more predominantly known as EXIST-2 for this particular trial. And it was a double-blinded, placebo-controlled phase 3, looking at 18 years old or older with at least one AML of 3 centimeters or more and a definitive diagnosis of TSC or sporadic LAM. It was randomized in a 2-to-1 fashion in favor of the treatment arm, and the dose was a little bit different. They started off at 10 milligrams a day, and based on effects, would titrate it down from adverse events or be a little bit more prominent in increasing that dose up as well if an effect wasn't done. Now, the primary endpoint was looking at a 50% reduction in total volume of that target AML. So not necessarily taking all the AMLs into account, but that target AML or that largest AML that presented them to the opportunity of this study. And we saw a response rate of about 42% that did hit that 50% reduction. And the median time frame was about 3 months. Now, kind of expanding that out a little bit further, at about 24 weeks, we saw about 55% of those within the treatment arm reach this primary endpoint. And by the end of the study, saw that at least 80% of the patients in the treatment arm had a 30% reduction in that target lesion. Now, secondary endpoints, we're looking at progression-free rates, and those with the treatment are the former numbers, while those in placebo arm are on the latter. And we can see that there is progression at 12 months, more significantly in the placebo group, where only 25% did not meet the designated term for a progression at that time. So with that, it was described as 25% or larger of the lesion, a new AML that had developed at greater than 1 centimeter, or an increase in total kidney volume, or had an AML-related bleed. Now, again, it's not 100% with the progression-free in the treatment arm. Was not really talked about very much on why, but there was 1 or 2 patients that ended up having significant effects of the medication and were stayed in the treatment arm but taken off of the medication. Now, looking at treatments, mTOR inhibitors, so sirolimus and everolimus, are first-line therapy in all asymptomatic patients. Now, a lot of these studies, again, are looking at about 3 centimeters or larger for that AML lesion, but in practice, we are tending to do it a little bit more earlier on than that 3 centimeter cutoff, whether it is purely because of renal or pulmonary involvement or neurologic involvement with SEGAs. We tend to be a little bit more aggressive in trying to treat these, again, because they are fairly tolerable medications with a limited side effect profile in comparison to their use with transplant, and again have shown very, very consistent and good results overall. Looking at, again, risk of hemorrhage, we want to try and prevent that risk of hemorrhage. And those that are on mTOR inhibitors tend to have that reduction, even though their size may be greater than 4 centimeters, they still have a reduced risk of this hemorrhage. In the TOSCA data that I mentioned, there were 3 that were treated with mTOR inhibitors that ended up having a renal hemorrhage. And all 3 of those had been off of their medication for at least 3 months prior to that event occurring. And the size range of that was anywhere from about 6 to 10 centimeters in size. So we do see some favorable effects of it. And again, if we're able to reduce that size, we limit surrounding damage to that normal architecture and try and help prevent that development of chronic kidney disease at a more rapid progression as if it was untreated. And we tend to see a little bit less adverse events in regards to proteinuria or significant glomerulopathy because of it that we tend to see in transplant. On those that receive this for transplant, we target troughs fairly high. So we start at a dose and really ramp up and have high dose, and over time we start backing down. Where in the management of this, we just want to get the medication on board and slowly go up based on effect. So we tend to start sirolimus or everolimus early on and say, hey, let's take 1 milligram and see how we do, see how we tolerate the medication. We'll get repeat imaging in 6 months or a year, and we say, hey, it's stopped the progression. Now, do we need to try and shrink it some more? Or hey, it's growing, but the rate has slowed down. Well, let's up titrate that medication there. And there hasn't been a consistent recommendation, as we can see with the different studies showing looking at different trough levels versus just a particular daily dosing or weekly dosing broken down over that time. But again, we start low and we build our way up based on response. So it is more tolerable for these patients. And that's one of the biggest complications or one of the biggest questions that patients and families have. Now, common side effects that we see, stomatitis is number one, by far and away the biggest one that I see, or aphthous ulcers. Again, we tend to treat that with oral steroids, different mouthwash numbing solutions. And again, it tends to be a little bit more cyclical for some reason or another. Other things, again, we have a little bit more propensity for nasopharyngitis or just some viral infections. We can see some acne. Again, similar to transplant, we really want to pay attention to their lipids and for proteinuria as well. Now, other options that we have are embolization and nephrectomy. So just kind of quickly going through some negatives for this is we have to do 1 lesion at a time. When we've done these at a couple of lesions at one time, they have significant negative effects on renal function. Not all lesions are amenable to this intravascular procedure. Again, as mentioned, some are not very vascularized, while others may just be in a very distant space where the vasculature doesn't lend very well for us to get there. There is a high risk of what we call post-embolization syndrome, which again, we think of it more like a SIRS response or something that we've seen with just in a generalized inflammatory response that we can compare a little bit with COVID. Could be as mild as pain and fever from days to weeks to as severe as ARDS. And this happens, the post-embolization syndrome can happen up to 90% if left untreated. But we've had a significantly reduced rate if we used a prolonged steroid taper of about 2 weeks, with the first dose being the day of the intervention. Now, again, with more of a physical intervention, we can have collateral damage to surrounding tissues, whether it's being the embolization or the nephrectomy. And the best estimation that we can get is about 50% reduction in that lesion. So again, with the medication, we see that very early on, within 3 months, but it's no guarantee that it can happen as well with the embolization. Now, I do want to point out this is the first line for an acute bleed from a hemorrhagic perspective. So if there's a life-threatening bleed, you need to jump to embolization, or if you're able to do a partial nephrectomy, if not able to do the embolization rather than a whole nephrectomy. Now, just again, overview of the treatment options that we briefly talked about. Now, in the treatment assist, there is no FDA approved treatment medications for cystic disease within TSC. Again, we look at the risk factor optimization or consequences of kidney disease. So we mimic a little bit of PKD here with blood pressure control, in particular RAS blockade, and then also looking at targeted CKD therapies. Again, hasn't been studied more recently with the newer population or the newer medications such as SGLT2, but again, the trend of management will follow along similar there. There is a question hey, we have this mechanism for TSC. Why are mTOR inhibitors not used for these cystic diseases? Well, uh, it's kind of a mixed results on when we see it. In the preclinical studies, we tend to see somewhat of an effect because of it, or with the mTOR inhibitors. But in clinical trials, we tend not to see these benefits. Now, is this related to the size of the cyst, the timing of initiation, or some of these cysts have already detached? All of those are valid concerns. But as of right now, mTOR are not used for cystic kidney disease related to TSC. And again, here's just a quick summary of treatment options. Now, I just want to take a moment on end-stage renal here. So, as mentioned, about 1 to 3% end up requiring renal replacement therapy, and that seemed a little low. Now, some of these, again, you have to remember patients that have intractable epilepsy or severe developmental delay. So you really have to weigh the risk versus benefits, where those at 1 to 3% that require that therapy may end up being the milder form within the neurologic or developmental pathway, where again, it may not be safe or beneficial for the patients, depending on the social situation and in a case-by-case basis on if these patients with severe delays and agitation and behavioral complications or behavioral issues that put themselves at higher risk if they were to receive dialysis. And then transplantation. So TSC is not a general contraindication to transplant. Now, every transplant institution has their own guidelines that should be followed. So, again, more cardiac age and other workup can prohibit some of these patients from receiving transplant, but just because of the diagnosis of TSC does not prohibit them from receiving a transplant. Now, I do have about 5 to 7 patients that have received transplants. The longest one currently is a living donor at about 23 years out right now. And what we tend to do is let the institution that they receive their transplant at manage upfront for the first 6 months to a year. But we really insist and try to work with them is once we're out of this post-surgical period and it is safe, to try and get them back on an mTOR regimen. So an example here, we are CNI and rapid steroid withdrawal for Cincinnati here. On these patients, we try to get them over to an mTOR inhibitor within 6 months to a year if all things are going well. Now, other questions are, do we need a nephrectomy or a native nephrectomy because of it, or serial imaging post-transplant? Some of these questions are worthwhile investigating, but have not been answered in any of the data or research that has been put out. So just kind of quickly going over the objectives. So identifying common clinical genetic characteristics of TSC. Again, it's an autosomal dominant sporadic disease with TSC1 and TSC2 that prevents inhibition of this mTORC1, which ultimately leads to overactivation, cell proliferation, and having multi-organ system involvement of these benign tumor growths. Again, it can affect 1 in 6,000 to 10,000 births across all racial and ethnic groups. Kidney manifestations that we commonly see, AMLs are the most prominent in decreasing fashion. And again, kidney disease is a top 3 cause in mortality in patients. Treatment options, again, our primary goal is to preserve natural renal architecture and prevent complications such as bleeding. The number one options that we have for AMLs in particular are mTOR inhibitors, first-line therapy, and then tissue altering therapy such as embolization or nephrectomy as a second line for asymptomatic, or first line for those within hemorrhagic shock or an acute decompensation because of a bleed. And again, generalized measures including RAS inhibition for those with cystic or just generalized chronic kidney disease. So I want to thank Dr. Vincent and everyone a part of the Africa Healthcare Network in allowing me the opportunity to present on a topic that's near and dear to my heart. I want to thank Cincinnati Children's for giving me the opportunity to be a part of this clinic, as well as the patients and their families, and allowing me to take care of their loved ones that have been affected by this disease. Okay, and I'll take a pause here and any questions.
All right. Thank you very much, Prof, for that comprehensive and enlightening presentation. I believe our viewers will have questions, but before they do, if I may take this opportunity to ask you a couple.
Yes.
So my first question is, when you suggested that especially patients who have got AMLs that are fat poor and it's difficult to distinguish between that and renal cell carcinoma, you suggested rather do a biopsy rather than doing a nephrectomy or partial nephrectomy. So my question to you is, if this is a renal cell carcinoma and we do a biopsy, what is the chance of seeding? Because these tumors tend to be aggressive, and the chances of seeding are high. Would that be a risk? And then my second question is on the cystic manifestations of tuberous sclerosis. You did mention that there is no treatment that is FDA approved. There is a query that you can use mTORs given the pathogenesis. But I was thinking along the lines of PKD, and if there is a role of using things like tolvaptan, especially if the patient's GFR is dropping significantly and there's nothing much you can do about, would that be an option to try? Thank you.
Yeah. So in regards to your first question, as far as the renal cell, again, that is a risk that is there with a biopsy. Again, it is one that we tend to see, but a majority of these lesions that we aren't able to identify as being RCC or fat limited AMLs, a majority of them are fat limited AMLs. Now, over the last decade, we are able to see a little bit better with our radiology colleagues in helping differentiate that. So what we tend to do is we tend to say close follow-up at 6 months with repeat imaging to look at the aggressiveness and the rapidity of growth. And if it tends to be a slow growth, we tend to just do serial imaging at that time. If we see characteristics that are concerning for RCC, and our pretest probability is fairly high, again, we jump straight to intervention rather than doing a biopsy at that time. With those that we are a little bit unsure of, again, very minute, very small amount of patients that we do end up doing this on, we do tend to favor biopsy, again, because of the more likelihood that this is going to be a AML rather than an RCC. But again, that risk that you mentioned of seeding is potentially there. Now, in regards to the second question with the cystic kidney disease, we tend to see a lot more. We don't see as much of the AD-PKD presentation. Now, I'm not aware of anything that's been studied as far as a tolvaptan in this population, but to me, it seems like a useful tool to have in our bag, that those that are presenting very similar to this. Now, in a majority of that population with the cysts, again, 50% of patients with cysts, these might only be 4 or 5 different cysts between both kidneys at a very small rate that just ended up incidentally being there as part of the disease process, and not a rapid growth similar to that of what we see with ADPKD. But in those that do have ADPKD like growth or that continuous gene, it is absolutely worthwhile in keeping tolvaptan as a tool to help prevent progression as best as we can.
Thank you, Prof, for those answers. We have a question from Dr. Amaswadi, who is also part of the AHN, one of the moderators, and is also a nephrologist and a physician. He asks, what would be the recurrence risk of the de novo disease if the patients were transplanted?
There is no particular percentage that has been thrown out. These are more case reports that we do see. As far as I'm aware, there's less than 5 cases that it's been reported in, and we tend to see it more in the lung transplant population that it has happened. But as far as risk of recurrence, there is a potential risk. But as far as a percentage listed, I would say it is likely less than 10%. But again, that is a risk that is there.
Thank you, Prof. We have another question from an anonymous attendee. Does the disease affect the liver as well? If yes, how commonly, and what is the presentation?
Yes, so it is a very common thing to see is angiomyolipomas or even cysts within the liver as well. As far as a particular percentage, we end up seeing it about 50% of the time. Presentations, again, could vary from anywhere from mild to association with NASH. As we end up seeing a lot more intra-abdominal fat deposits just globally within the abdomen, which then could lead to a little bit more of a NASH picture or a NAFLD picture that can present there. Often when we manage these liver lesions, again, we look at the malignant potential being on the lower side, but if they tend to cause disruption within the parenchyma or compression on other structures, leading to complications, then we end up performing hepatectomies or partial hepatectomies because of that.
Thank you, Prof. We have a question from Professor Dima, who's a pediatric nephrologist from South Africa. Is there a role for SGLT2 inhibitors as part of CKD management?
I would say yes. Has it been studied in the subset of population? No, it hasn't. But I would favor it to be used in the CKD population, like we are starting to use initially with diabetic kidney disease, and now just in general CKD progression as well. So I do think it has a role there. Now, one thing that interests me a little bit, as I mentioned, there is a predominance of intra-abdominal fat deposits that we tend to see. And I'd be interested to see the effect of SGLT2 on the effects of that fat deposit in these patients, as well as the liver disease. So is there a metabolic component that the SGLT2 could help in the management of these patients that we really haven't described very well up to this point?
Thank you, Prof. Potential question for research paper pretty soon. Dr. Lloyd is actually saying that he thanks you for this phenomenal presentation. He has learned a lot from you, and he asks if the mTOR levels are similar to those for transplant doses.
Generally, the patients that I have tend not to have as high of a dose as mTOR inhibitors. A lot of them deal more with some of the side effects. These patients are very sensitive. Again, those that are on the spectrum or some developmental delay tend to be very, very sensitive sensory-wise, and more negative effects in their mind from some of these aphthous ulcers that can happen. So we tend to start very low and build our way up as it's tolerated. The range or the trough range that we can look at can go anywhere from 3 to 15. Typically, those with transplant, post-transplant, I look at about closer to 8 to 10 myself at least starting out. But we start very slow, very mild introduction of the mTOR inhibitor and just build it up over time to effect rather than a level.
Thank you for that. Dr. Lloyd, would you like to ask your question on the prophylactic role of mTOR inhibitors in adolescents?
Yeah, is there a role for mTOR as a prophylactic drug, in children, when you actually have genetically diagnosed them and not yet overtly symptomatic? Is there a role in giving them, because it could be possibly nephron sparing or prevent aggressive disease? If I'm right, I am not.
Yeah, no, you're exactly right. That is the way that I operate. Is there much data behind it? No, there is not much data behind it. Again, a lot of the data that we have for mTOR inhibitors in this disease are those that do have large AMLs already at presentation. But again, in my mind, I think that is one way that we're ultimately going to be going in the future is maybe a little bit earlier onset and starting when maybe we have 1 centimeter or less, or we're starting to see some of these changes just to prevent the negative effects downstream over time.
And this will possibly be lifelong once we start on them and then adjust the doses and we look at the toxicity if there is an decrease in dose.
Absolutely. Yes.
That's wonderful. Thank you very much. It's a wonderful presentation and it's an eye-opener. And the amount of work is phenomenal. Wonderful.
I appreciate it. Well, thank
Maybe
you
we
again.
can take one final question, Prof, if you have some time. So
Absolutely.
the last question is on how do you manage the facial skin lesions of tuberous sclerosis? So
just to just to repeat that I understood correctly, how do we manage the facial angiomyofibromas? Is that correct? So those with systemic therapy tend to have a response. So those that are placed on mTOR inhibitors do have a decrease in the amount of fibromas that they have. There is topical mTOR inhibitors that is a very common way that we treat that still remain a little bit prominent. So I do have a few patients that have had negative consequences because of the mTOR inhibitors or more family-related questions to not putting on systemic therapy and are willing to try these topical mixes of mTOR inhibitors, which have a really good response. There are some surgical interventions, but these are very vascularized lesions and tend to, if we do a lot of surgical intervention, tend to leave more scarring, which can be a different effect, but it would not always be beneficial for those lesions. So mTOR inhibitors for another indication, whether it be in systemic or a topical therapy.
Right. Thank you very much, Prof.
One last question, one small thing is does this present to the pediatric population in a great deal? Is it first diagnosed? Can it be easily diagnosed from the pediatric side, at least suspected from the pediatric side based on skin lesions? Do they come up that way?
Yes. So the number one way that I would say is skin lesions or neurologic components. So seizures or tics or developmental delays are probably the more common if it was sporadic early childhood that do not have the inheritance pattern that we typically would see. But again, the presentation, if we do have a known parent that does have TSC or with the more up-to-date routine obstetrics, we can see sometimes a cardiac rhabdomyoma, which can be seen there. So a personal example for me. So my wife with it, our first two children are disease-free, but our daughter who is also has tuberous sclerosis. Again, without doing the intrauterine genetic testing on everything, which again could be a completely separate talk. About 32 weeks along, we noticed a rhabdomyoma in her heart again at about 32 weeks, and then again the association was very high. So it can be diagnosed during pregnancy, but also it is likely more of a neurologic aspect to it with the derm findings that would prompt that diagnosis in early childhood from a sporadic distribution.
All right, Dr. Lloyd, one last question before you go ahead with the closing remarks. So somebody is asking, is there gene therapy research? So I believe it's a question is about gene therapy and tuberous sclerosis.
Yes, gene therapy, I do believe it's coming. It will not be as straightforward as something like Fabry's disease. So the effects are going to be a little bit tricky because of the systemic involvement and the different presentations within the different organ involvement. I do believe it's coming. There is likely more benchtop research that is actively ongoing in that realm, but there's no clinical trials at this point in time that I'm aware of for gene therapy.
Thank you very much, Prof. Thank you very much again for your time and for this insightful presentation. Dr. Lloyd, kindly please for the closing remarks.
Yeah, no, thank you very much, Jake. This is a phenomenal presentation. It's an eye-opener, to us in this part of the world, and extremely grateful for having taken time to tell us about TS. And it's only now that we know that so much work is being done on tuberous sclerosis, and we hope to put this up on YouTube, and it will be a learning for a lot of us. At the same time, it's also good to know that there is one center, a really big center in the US focused on the disease, and great work, and I wish you all the very best. Thank you for spending time with us. So thank you very, very much. It's a wonderful presentation.
Thank you for the kind words and having me. It's been a pleasure.